Good morning. Thank you for joining us on this hot, humid July day. I'm Erin Shaughnessy. I'm the new Division Chief for the Kids Link Hospitals Division, and I have the pleasure this morning of introducing our distinguished speakers to talk to us about a problem that happens in hot, humid days. So Dr. Rebecca Sunenshine is the Medical Director and Division Administrator for the Disease Control Division at Maricopa County Health Department. As a CDC Career Epidemiology Field Officer assigned to Arizona since 2006, she has served at the Arizona Department of Health Services for 4 years and Maricopa County Department of Public Health since 2010. Dr. Nick Staab is a hospitalist here at Kids Link and has been here since 2015. Prior to his medical training, he earned a Master of Science in Public Health Microbiology and Emerging Infectious Disease at George Washington University. He worked for Maricopa County Department of Public Health and Arizona Department of Health Services as an infectious disease epidemiologist. Thank you for joining us.
All right, good morning. Thank you everyone for coming this morning. And a special thank you to Erin for the introduction and to Rebecca for helping me put this presentation together and then continuing to encourage me to be involved in public health and pursue my interests in public health. So our goals this morning for this presentation are a few: to review the basic Zika virology and epidemiology, to describe the acute Zika infection, and most importantly, I think for this crowd, to review what we know about congenital Zika syndrome. And then lastly, to update all of you on the current guidelines for testing and reporting suspect cases to public health. Just one caveat to this morning's presentation, as Rebecca reminded me this morning. Recently and worldwide, we're seeing a significant downtrend in incidence of Zika infections. So I commented at Sign Out this morning that was disappointing for me with a background in epidemiology. But I think for most of us, that's an encouraging thing. But the important takeaway is, even though we're seeing decreased incidence worldwide, we as pediatricians are going to be dealing with this for years to come, as this large cohort of patients who are exposed to Zika in pregnancy comes to our attention and comes to our care, and dealing with their special care needs. So let's see. So this is a disclaimer. I think it's Rebecca's disclaimer, not mine, but there it is. So Zika virus, we know, is a single RNA stranded virus, a member of the Flaviviridae family. It developed and came to attention, or developed, we think, in Uganda around the end of the 19th century. There are two known lineages. One is Asian and one is African, and that's pretty much where Zika has lived prior to recent time. The full genome was first identified and published just in 2007, and until 2007, it was primarily an infection for wild primates with only occasional spillover into the human population. If you come across it on the street, that's what it looks like on the right, and just a graphic of what the virion particle looks like. I think the most important thing to know about Zika virus is just how it's related to other Flaviviridae, and then specifically in terms of developing vaccines and looking forward to other modes of prevention. Its structure is very helpful, but that's about all. Probably not relevant to us for the most part. So here's a phylogeny of the Flaviviridae, just to remind you some of the other viruses that Zika is related to. So popular ones that you'll all know are West Nile, St. Louis encephalitis, Japanese encephalitis. Importantly, dengue is probably its closest relative here. And so we see a lot of cross-reactivity in terms of testing with dengue virus, and similar presentations to dengue, which we'll talk about later in the presentation, how to distinguish those. Yellow fever is important because we have a successful vaccine against yellow fever, and it's being used as a model for looking into ways to vaccinate against Zika. And then just a reminder here of basic epidemiology, 3 different parts to describing epidemiology. You need a host, a vector, and an agent. So for the known agents here of the Flaviviridae, most of them, I'm kind of ignoring the tick-borne encephalitides, but are transmitted through a mosquito vector. The difference between like West Nile virus, which has been popular here in the valley before, is kind of the difference between an amplifying host being birds versus us. So that's kind of a distinguishing factor there. So just briefly kind of where we've gone in time. So we think around 1947 was the first time that Zika was identified as a unique agent in Uganda. It was initially identified as an infection of rhesus monkeys. From 1947 until 2007, there were 14 reported cases of Zika virus, so a long time. We're just seeing sporadic cases. Like I said, it was just spillover into the human population. And then in 2007, there was an outbreak in Yap, Micronesia. So we're looking at this small dot over here. Interestingly, so I mean, Yap is an island state in Micronesia, only about 120 square miles, about 11,000 population. There were 49 cases reported in that outbreak, and that was pretty much the end. It was all contained there probably for, it was a contained place, so it didn't spread. So all was kind of quiet until 2015, when it was first identified that Zika was in Brazil. So May of 2015 was the first detected case. About 3 months later, there was noted to be an increased number of Guillain-Barré cases in the affected states where Zika was being reported. And then by December, so 7 months into this timeline, it had spread already to 18 states in Brazil. And 3 deaths were reported at that time, identified or linked with Zika virus. So through the end of 2015, there was noted to be an increased number of microcephaly cases, which I'll kind of review when we talk a little bit more about congenital Zika syndrome in the northeast part of Brazil. And this is an old number, but about 4,000 cases of microcephaly had been reported initially then. I like this slide because it shows how over a relatively short period of time Zika spread up through Central America, through South America and Central America. So October 16th of 15, while things were growing in Brazil, there were cases in Colombia. Through November, it went up through through Venezuela, Paraguay, El Salvador, and Mexico. And then in December, pretty much it spread throughout Central America. So this is a recent map from the CDC just showing the extent of Zika virus infections throughout the world. I didn't intentionally leave off this part of the world. It just fell off my picture. So currently in the continental United States, as of the end of May, we're looking at about 5,300 confirmed cases. 5,000 of those 5,300 are travel-associated cases, which kind of emphasizes the importance of knowing where your patients have been in terms of risk stratifying their exposure. 1,800 cases have been identified in pregnant women. 46 of those 5,300 confirmed cases are being labeled sexually transmitted. So while we know that that's an important mode of transmission, in terms of the number count, it's relatively low. So 224 of those 5,300 cases are locally acquired. So I think that's what we all kind of get excited about in terms of where this infection is going. 218 of the 224, so the majority, were in Florida, and there were 6 cases in Texas. Just by comparison, for the U.S. territories to date, we're looking at about 38,000 cases. versus the 5,300 in the continental US. So just a lot more other places, but it's where we live, so it's important. As of December 9th of 2016, there's been no known local transmission of Zika virus in the continental US. So just a graph to further hone in on that point that the large blue column there in the center in 2016 was travel-associated cases versus a relatively small number of locally transmitted cases, and then a handful of others. And then here's kind of the point that we talked about earlier. So these 2017 cases are, again, just from the month of December in 2017. And we've seen no cases since then. Sorry, we've seen no locally acquired cases. These are travel-associated cases, so they could be continuing through 17. This is an irritating slide because there's too many words, but I like it because this describes the locally acquired cases in Texas that occurred at the end of 2016, October through December. And I think it's just an interesting thing to read through, because I think if we were to see locally acquired cases here, it would occur in a very similar fashion. So to just kind of see how, from over the course of 2 months, 6 cases were identified locally. That's that. All right, I'll turn it over to Rebecca for a bit.
Good morning, everyone. Hey, first I just want to acknowledge Dr. Lisa Villarroel. Sorry, Lisa. She's sitting right there in the back, and also Tim Flood. They are 2 physicians from Arizona Department of Health Services who joined us today. And Lisa Villarroel is the medical director for Epi and Disease Control. And she is here because CDC rolled out new guidelines yesterday at about 4 p.m. And we actually have been doing this together, basically going around and doing grand rounds. So I'm really happy that she's here to help me answer questions about how we might interpret those new changes, and also many of these slides are hers, so I want to acknowledge that. So these data that I'm showing here are the total number of Zika cases that have been confirmed in Arizona total. There have been 57, 36, or about 2/3 of those have been in Maricopa County. Only one of those has actually been confirmed in 2017, and that is from Maricopa County, I believe, in January. So we have not had any confirmed Zika. These are all travel associated, or a couple sexual transmissions, but nothing local. And we've not seen anything since January in Maricopa County. So in 2016, I'm just going to cover the data because that's where we've learned the most about the epidemiology in Arizona. We had over 1,000 reports investigated. There were 56 cases in Arizona total, and it makes it look like they were Maricopa County, but again, 36 of them were Maricopa County. They were almost all travel related, and 75% of those are female. And I think in the very beginning, we all saw 75% are female, and we thought, oh, well, that's testing bias. That's because people know this is associated with microcephaly, and women are coming and getting tested more often. And so we were all kind of going on that, but they've really looked hard into this in places like Puerto Rico and South America, and it seems to be even more than that. So it's probably some testing bias. There's almost definitely some contribution to the fact that this is sexually transmitted, and we know that it's much more likely to be transmitted from a man to a woman than a woman to a man. So they're probably getting bitten by mosquitoes at the same time as they're having activities with their partners. I don't know why I couldn't come up with that word. They're at risk for getting sexual transmission, and then on top of that, there may be some behavioral bias where women are more likely to go to the doctor. All of those things combined. So of the 29 where we have known ethnicity in Maricopa County, 23 or almost 80% of them are Hispanic. So we are seeing this in our Hispanic population. I also want to let you know that we have 25 unaccompanied minors who left Maricopa County. They are not in our numbers, but they're really important because they're coming to us from the Office of Refugee Services. I didn't quite get that right. What is it, Lisa? Okay. Office of Refugee Services, and they're basically Mostly teenagers. The average age is 15 or 16 who've migrated in through Central America and literally trekked hundreds of miles outdoors in mosquito-infested areas. And tragically, a lot of them have been sexually assaulted on the way. So one study from Texas showed that about half of their female unaccompanied minors came in pregnant. So we don't actually know the proportion here, but when they do arrive pregnant in the refugee centers, they are provided with testing and follow-up at OBGYNs. And it's very challenging because they often are relocated with family members here in the United States before we can even get those testing results back. So we've really been taking a hard look at that here in Arizona and Maricopa County and trying to shore up those processes. And we've also had a viremic blood donor, and it's important for you guys to know that every single pint of blood that is donated here is tested by a nucleic acid test for Zika, which is incredibly sensitive, way more sensitive than the clinical assays that we have. Also important for you to know, and this map is an older map, but it's important for you to know that there is a section of Arizona Department of Health Services, the Border Infectious Diseases Surveillance Group, and they have a very close relationship with Sonora, Mexico, which is along the Arizona-Mexico border, and they do cross-border investigations all the time, and Sonora is doing really good surveillance for Zika virus. They are testing all the symptomatic folks and anybody who is at high risk of Zika, and when they do document a local case, or any local spread, they report it to Arizona Department of Health Services, and they produce this map for us weekly. So we know how many cases have been in what part of Mexico at what time, specifically Sonora, and they update that map and share it with the counties every week. And that's important because when you guys have cases that have been exposed in Mexico, we drill down right to the city and look at how long they've been there, and we look at risk that way. So in September 22nd, 2016, the first local case of Zika was reported in Sonora, Mexico. That was a really big moment for us because before that, most of the cases had been in southern Mexico, and we thought, oh, we're still safe. It was a small agricultural town called San Miguel de Orcasitas, approximately 300 people. However, even though it was September when they found it, they realized that transmission dated back to July. So if you count, that's about a 3-month delay before you're going to identify local spread. Now, I've listened to the Florida folks talk a lot, and they think that there was at least a 2-month delay before they identified Zika. So this is a disease where 80% is asymptomatic, where Dr. Staab is going to go over in a little bit. So it's going to be really hard to pick up right away. There was a second, I call it a cluster, but I'm told later that it was only one case, so it was never officially confirmed as a cluster. Total, they had 25 local cases, but they have also not had any since January of 2017, which is important for us here. These numbers came directly from Dr. Villarroel and ADHS, and what's important about them is when you look at all of the cases, the breakdown of where they were exposed in South and Central America, you can see that about 29% were actually exposed in Mexico. So that is our biggest risk, and you guys really need to take Mexican exposure seriously. Another third or so was in Puerto Rico, and we know that there's a ton of spread there. Also Central America, Caribbean, and South America. All right, this is sort of an obvious slide, but we're trying to use more pictures because it's 7:30 in the morning. I think most of you know that people get Zika virus by a mosquito bite, and this just shows the transmission. And I want to remind you guys, this is not obvious to non-epidemiologists or even a lot of epidemiologists, but when an infected mosquito bites a person, I think you guys are all aware that there's about a 7-day up to 14-day incubation period. But what we may not realize is that there's an extrinsic incubation period where the mosquito then has to harbor the virus for about 10 days before they become sick, which I don't know what mosquito symptoms are, if there are any, and then they can transmit it effectively to a human. And the reason why that's important is because, do I have a pointer? Is there a pointer in here? Yeah. Top one? Which one? Yeah. Okay. So if we can get that guy sometime in that 10 days by spraying or swatting or whatever it is, or by doing prevention methods, we can stop local spread. So that's really important. And of course, this is where they buy They bite predominantly happy couples. And then they get infected, and then they actually have to bite them while they're viremic, which is actually about a week long, and then spread it to other people. So as you know, other ways people get infected are, we talked about through blood transfusion, and one of the things that they found out when they looked back retrospectively at the YAP outbreak is they believed that about 2.3% of the population was actually infected based on blood data. You can, mothers can transmit it vertically to their children, and they can also transmit it perinatally during birth. And lastly, there's the happy couple who could potentially transmit it sexually. Mosquito transmission, so it's 80 species that can transmit Zika, and there's two subspecies, Aedes aegypti and Aedes albopictus. And it's important for you guys to know that Aedes aegypti is the most capable species of transmitting Zika, and we don't have any albopictus here. So when you see that all those places on the East Coast in the United States, they all have a lot of albopictus, and it can transmit, but not as efficiently as aegypti. And we'll talk more about aegypti in a minute. Infected humans are the reservoir for the viruses, for Zika and also for dengue. So Aedes aegypti bites mostly during the daytime. Now, Arizona is unique. I don't know if you noticed, it gets a little warm here in Arizona. So when I've talked to the folks in Fort Collins who are the entomologists, they say, we don't think any mosquitoes can survive in 120 degrees. So our Aedes aegypti have adapted to the heat, I am told. They are so unique that they probably bite a lot during the day, but they're probably also biting at dusk and dawn. So here's what I want you to take away. Those suckers are going to just constantly be biting. So forget anything you ever heard about West Nile, about dusk and dawn. Just use mosquito repellent and get your patients to use it all day long. They're classically ankle biters. So you want to wear socks, or you want to wear mosquito repellent there. They'll get right around your ankles. And they breed in backyard containers. A lot of people think, oh, it's just like West Nile. If I take care of my pool, I'm good to go. These guys will breed in smaller containers like dog bowls, pet dishes. How many of you have kids? No kids? No kids. Okay. Those toys, those little riding toys, all their little buckets, these guys can breed in a thimble full of water. So that much water collected in the toys in your backyard, they can breed in. So you want to turn your toys upside down. And if you're wondering how much Aedes aegypti we have in Maricopa County, these are some examples of all the places you need to look for breeding. This is a map that we have from 2012 to 2014, and it's gotten worse. And every dot that you see is where we've found Aedes aegypti in pools of mosquitoes. And this is everywhere in Maricopa County. So we have so much Aedes aegypti here that there is no place that is spared. So we all need to be really conscious of prevention messages. This is a great graph that I pulled from Dr. Villarroel's slide, and what's important for you to know here is that this represents the day of the mosquito biting the human. Roughly 7 days later is when viremia occurs, and that's when, if another mosquito bites that person, it can spread locally. Same time, viral RNA is peaking. And then right here, sometime around day 4 after viremia, and we used to think up until 12 weeks, you see this peak of IgM. What we've learned now in the last, I would say, 6 months is that the IgM probably persists longer than 12 weeks in many cases, which makes it very difficult to interpret it, especially in pregnant women. And then you get this IgG peak, as you do in most other communicable diseases. So I don't want to go too much into the individual studies. They used to be really important, but these data have changed so much. There's basically 2 studies that have looked at persistence of Zika in body fluids. This one was in predominantly symptomatic individuals, and then Florida did one in all comers, symptomatic and asymptomatic. And here are the take-home points. Bottom line is, in this particular study, bottom line is they found in the Florida study that there was more Zika in the urine and that you're better off getting a urine. In the Puerto Rican study, they found that you're going to have a higher Zika viral load in the blood and that you're better off getting blood. And so what I want you to take home from this is you want to collect urine and blood. Now what you can see in this slide is in the serum, In regular people, non-pregnant people, it lasts about 14 days in the serum. And then in this particular study, it was up to 46 days after symptom onset. These are in symptomatic pregnant women, and we now know it can last much, much longer in pregnant women. In urine, it was a median of 8 days. Again, in the Florida study, it went all the way up to 14 days. And in the semen, and this is a big takeaway point, which is why we left it in here, you can see that there was about half had positive RNA in their semen. The median time to loss of detection was 34 days. So most men have it in their semen at least a month. And then 11 of 55, it lasted up to 125 days, and the study wasn't even completed when it was done. So that's where we get those really long time frames of 6 months that men have to wait before they can help a woman conceive, because it persists for a very long time in the semen. And also, it's important to know that there's not much RNA in saliva or vaginal secretions, 2% down there. That's why we know that women don't often transmit it to men. Prolonged viremia in pregnancy, this was a pretty big study where Zika RNA was detected in the serum of pregnant women at 4 and 10 weeks after symptom onset, and there was another smaller study, and they basically showed that it could be detected for months and months in pregnant women, where we thought it was really only going to be detected up to 14 days. And this is hypothesized to be due to delayed immune clearance of the viruses due to altered immunity during pregnancy. And so basically the fetus is getting constantly exposed, and that increases the risk of the fetus getting infected. I think this is you.
So I think for this crowd, I think a lot of the clinical aspects of the infection are particularly interesting. And so this is a little segue here. So as Rebecca noted earlier, about 1 in 5 people, or about 80% of Zika infections, are symptomatic. So again, that can kind of explain the delay to seeing where these cases are popping up, and just underlines the importance of our awareness of these, the potential of these infections. So the symptoms that you can expect to see include the most common symptom that we're seeing, and this is in adult studies, are maculopapular rash. So I have a picture here of a rash that you could expect to see. So generally all over the body, not really specific to any particular place, but the rash has been identified in about 90% of symptomatic cases. Aside from rash, you can have a low-grade fever in about 2/3 of patients, arthralgias and myalgias in about half. Headache has been more recently added to the syndrome and is seen in about half of cases. Conjunctivitis in about 1/3 to a half, and then retroorbital pain. So eye symptoms are an important piece of this puzzle as well. Symptoms normally last for anywhere from 2 to 7 days. And then, as in a lot of our pediatric infections, the data in children is a little sparse. But this was one study that looked at about 158 travel-associated cases in children less than 18 years old. So the median age was about 14 years, but spanned a month to 17. 56% of those included in this study were female. And there you kind of see the breakdown of symptoms in this pediatric population. So they're all a little less than those statistics I just read out. So, 82% had the rash versus 90% in adults, fever in 55%, conjunctivitis, and arthralgias. 54% of those presented with both fever and rash. We know that Zika virus is associated with Guillain-Barré, and we've seen increased cases of Guillain-Barré in areas where Zika is active. In this case, in this study of kids, there were no cases of GBS in the 158 cases evaluated. So the differential diagnosis for acute Zika virus infection, obviously I mentioned earlier that dengue is an important consideration, both in terms of areas of exposure that these kids could be coming from, and then in symptomatology. Less frequently chikungunya, and then the rest of these all are important differentials to include, especially other pediatric cases, rubella, measles. I think most commonly we probably would see a lot of these cases and just automatically say, oh, that's probably adeno or enero, especially during the summer season. I think if you're considering any of those cases, it's really important, or if you're considering any of those diagnoses, it's really important to get the travel history and see what possible exposures these kids could have had before saying that's absolutely it. So clinical features to distinguish Zika from from dengue virus, so another flavivirus, and then chikungunya. So I think the important distinguishing characteristics here are that Zika is much more likely than the other two to present with rash and conjunctivitis. Specifically to distinguish dengue from Zika, if you have any hemorrhagic signs, any bleeding, obviously dengue goes much higher on your differential than Zika. And generally speaking, with acute infections, dengue infections tend to be much more severe than Zika virus infections. So as I mentioned earlier, with the worldwide incidence of Zika becoming lower, I think our role in identifying congenital Zika syndrome and then following these kids through their childhood is going to be really important, and a special role that we can take. So this was from an early report of cases of microcephaly in Brazil during the early stages of the epidemic there. So essentially what you see is what's important here, and it's that there is a drastic increase in the reported cases of microcephaly in 2015 with the onset of Zika in Brazil. And specifically, we see it in states in Brazil where Zika was known to be transmitted more versus other states. So in March of 2016, article in the MMWR noted that there is an increased number of cases of microcephaly in Brazil where Zika was being transmitted. So this included an analysis of 570 cases of microcephaly. It linked those cases both geospatially and temporally to Zika transmission, and importantly also was the first time that we really identified that Zika infection in the first trimester of pregnancy for these moms was most closely linked with developing congenital Zika syndrome. As I noted earlier, the prevalence of microcephaly was in 15 states with highest Zika transmission, and so that was in March of 2016. This was an article from the New England Journal of Medicine in May of 2016 that just officially kind of evaluated the cases of microcephaly and the link between Zika virus and the congenital findings that were being reported in newborns. And then by August of 2016, a much larger case series of 15,000 live births from Brazil was completed. That kind of helped better summarize the findings of congenital Zika syndrome. So we know that the findings in these babies can be very similar to what we see in congenital rubella and CMV infections. And so again, if you're seeing a baby or considering those congenital infections, getting a travel history for the mom, an exposure history, is really important to possibly being able to identify these babies. So as was noted, the most common feature, the most prominent feature is microcephaly. And this is believed to be, a lot more research has been done on the pathophysiology of Zika virus, and it's known to be a neurotropic virus similar to rubella and CMV. And so we have fetal brain disruption sequence, which is kind of the fancy way of describing why these kids end up becoming microcephalic. In this initial report, the greatest risk of microcephaly, as I mentioned, was noted with infection in the first trimester. Sensory neural hearing loss is a prominent feature in these kids. Also, ophthalmic lesions. So the ophthalmic lesions can include focal pigment modeling of the retina, chorioretinal atrophy, and optic nerve hypoplasia. Orthopedic lesions. So again, coming from this brain disruption sequence idea, there was a noted increased number of cases of babies with arthrogryposis. So another feature that could make you think of congenital Zika syndrome. And then obviously the whole thing is a spectrum. So what features you see in these kids can be from severe to relatively minor. This was an article that came out in MMWR in 2016 as well, December, that looked at congenital Zika syndrome in cases that didn't have microcephaly. Because initially, the microcephaly is what led us to kind of come up with this definition for CZS, but here was a number of cases, so 13 infants in Brazil who did not have microcephaly. And I think what is most important about this, and what was commented on, was there is not really a standard definition of microcephaly worldwide. So what we consider microcephaly as a definition here is not necessarily consistent worldwide. And so I did just want to review here for everyone just what we define microcephaly as: less than 2 standard deviations below the average in the population you're considering. So obviously most of us use CDC and US population data in terms of looking at those standard growth charts. Can also be defined as less than 3rd percentile. So it's important in understanding any of these studies that look at microcephaly and to consider what they're using as that definition. So just a bunch of other features that have been seen in congenital Zika syndrome. So hip dysplasia, dysphagia, epilepsy. In this small sample, all of the patients were hypertonic, but importantly, 12 held eye contact, so that was not important in distinguishing them. And then in this test, or in this study, 11 tested had normal hearing evaluations. From a previous test of 70 infants with Zika virus infection, 5.8% of those had sensory neural hearing loss. So your initial hearing screens may not be able to help pick up these kids. I'm neither a radiologist, nor do I have I don't feel real comfortable with this, but I included these in case anyone's interested in what the features are for the neuroimaging. I think in this study of 22 cases of congenital Zika syndrome, on CT, 100% of those cases had calcifications at the junction between cortical and subcortical white matter. So that seems like something we should be looking for if you're trying to use your imaging to help distinguish the case. And then 95% had malformations of cortical development. So we're looking at the cortex really for these changes. On MRI, we again see those calcifications at the junction between cortical and subcortical white matter. And then importantly, the malformations seen were symmetrical in almost in 3/4 of the cases. All in all, we're looking at current estimates for the risk of congenital Zika syndrome for moms who are infected in the first trimester are anywhere from 0.8 to 13%. So we're still looking at a pretty wide risk factor there, trying to hone that down to find out exactly what the true risk is. So here in the U.S., the CDC runs a Zika pregnancy registry where moms who have positive Zika testing in pregnancy are reported. So this was from an MMWR article, April 4th of this year, reviewing the initial analyses of the pregnancy registry. So 10% of pregnant women with confirmed Zika virus had babies with birth defects of all sorts. So again, I just said 0.8 to 13.2 is kind of the reported risk in the literature. This evaluation showed about 10%. The highest risk was noted to be in the first trimester of infection, where we saw about 15% of women who tested positive in the first trimester had some birth defect in the pregnancy. 1 in 3 babies with possible congenital Zika syndrome had no report of any Zika testing at birth, and only 1 in 4 babies with possible CZS had any brain imaging. So I think this just kind of showed us that we were, in terms of doing the appropriate surveillance, weren't quite where anyone would want to be. So again, here you just see, so of all the live-born infants with birth defects, here the percent getting any neuroimaging at all was only 64%. And then this is just in terms of the testing and how many were tested positive. So 56% had a positive Zika test when the baby had birth defects and the mom had a positive test during pregnancy. With birth defects compared to without, and then the totals here. Again, I think highlighting the fact that we were not doing a very good job at getting the appropriate neuroimaging in cases that were suspected. This was from June 16th of 17, so that would just be last month. So this was a review of data from U.S. territories that showed that about 5% of fetuses and infants born to women with any evidence of Zika virus during infection had some sort of Zika-associated birth defect. So again, if you're looking at that 0.8 to 13% risk factor, this evaluation of the data shows about 5%. Interestingly, in this evaluation, the incidence of microcephaly and any other abnormality were seen with infection during every trimester of pregnancy. So just to reiterate that while we see more usually during that first trimester, every trimester is possible. And those numbers were 8% during the first trimester, 5% during the second, and 4% during the third. This was encouraging. There was a significant improvement, at least in looking at this data, in the number of cases of suspected congenital Zika syndrome who did have some sort of screening after or postnatal imaging. So improvement at least to 50%. So all of this led the CDC to publish their guidance for infant neuroimaging and testing following birth in suspected cases. And it's certainly looking at this doesn't make me want to follow their recommendations. But importantly, to try and summarize those, for any newborn infant with anomalies consistent with congenital Zika syndrome or known positive Zika testing in the mom, the recommendation is for first a head ultrasound followed by an MRI versus a CT. As Rebecca noted earlier, we need to get both serum and urine specimens on these kids, ideally within 2 days of birth. And currently, the recommendations are to get nucleic acid testing, PCRs, and IgM antibodies on those babies. And then placental testing is really only indicated in the setting where you're trying to confirm the mom's exposure. Placental testing will say nothing about the infant's risk for Zika infection. If the mom is exposed to Zika virus during the pregnancy and has no Zika testing, and the baby has no features of congenital Zika syndrome, the recommendations are to test the mom with a PCR, and then to collect serum and urine from the infant and hold those for future testing pending the mom's results from testing.
Okay, I'm going to briefly go over Zika testing highlights in adults. These change regularly, and I think I mentioned they changed yesterday at 4 p.m. So we're going to do our best to really cover the big points. So I mentioned that viral RNA can be detected in the serum typically for up to 14 days in non-pregnant individuals. And just so you know, PCR is sort of what I learned in my training, but CDC refers to it as NAT or nucleic acid testing, so you should think of those as interchangeable. We do recommend getting serum and urine. Again, there's, depending on whether they're symptomatic or not symptomatic, sometimes one is better than the other, so we're always going to get both. Classically, the NAT testing or PCR is very specific, but not sensitive. What that means is a positive is almost always a true positive. And I say that because we have seen some commercial PCR assays that are false positive. So nothing is an absolute here. But for the most part, if you have an appropriate travel or sexual exposure with a positive PCR, it is likely to be a true positive. And we do know that the viral RNA persists longer in pregnant women, so beyond the 14 days, up to many months, and also in the semen. IgM antibodies, as we talked about before, they start to peak at 4 days, and they go all the way up to 2 weeks. As before yesterday, we were thinking that it was up to 12 weeks, and now we know that it can be much longer. IgM is very sensitive but not specific, and that's because, as Nick mentioned, they cross-react with other flaviviruses. And just a reminder, because this was hard for me to get in the beginning, flaviviruses are everything that you've heard about in this talk except chikungunya. So chikungunya is an alpha virus and it does not cross-react. So really what you want to worry about is dengue, because everywhere that Zika circulates, dengue is also circulating, and you also want to think about West Nile because that is circulating here. Friday, we had we announced our first West Nile death of the season. So those are the two that you want to think about with cross-reactivity on this IgM. Because it is so sensitive and so very not specific, it has to be confirmed with a plaque reduction neutralization assay. Up until very recently, those could only be done at CDC, and they took sometimes weeks to months to confirm. However, the state lab just got the ability to do the plaque reduction neutralization assay, which we believe will decrease the turnaround time. However, we haven't had any cases to validate it yet. So we do have the ability to do it. It's not fully validated. And right now, as of yesterday, it came out officially, and that's why we left some of these handouts that say key takeaways. These key takeaways are focused on pregnant women only, and I say that because they didn't even mention any new recommendations for non-pregnant women and men. So they're focused on that, but because we've had so few confirmed Zika cases, not only in the continental U.S., but also in the U.S. territories and in the world, we've gotten to a point where the prevalence, put your epidemiology hats on just for a minute. Remember that whole positive predictive value and prevalence thing where the incidence of disease or the prevalence of disease is so low that you're more likely to get a false positive than you are to get a true positive. We just crossed that threshold yesterday at 4 p.m. So they are now no longer recommending the IgM test for asymptomatic. Now, they've never recommended it for asymptomatic cases who weren't pregnant. Now, pregnant women who are asymptomatic, they are not routinely recommending the IgM. And that caveat is for pregnant women who have only been exposed briefly, okay? Asymptomatic pregnant women who live in a region where there's ongoing Zika transmission, they're still not recommending IgM, but they are recommending PCR or NAT testing once per trimester. Okay, so who to test for Zika? I'm going to keep this really basic because I want you to get these takeaway points. Bottom line is anybody who has those symptoms. Remember, a symptomatic person with Zika almost always has a rash. The one thing we've learned since we put together that table, you know how it highlighted that you're more likely to have conjunctivitis in Zika than you are in the other ones? For some reason, Puerto Rico, who's had 40,000 confirmed cases, they've noted that we don't see conjunctivitis very often. So rash is what you got to go on. You guys don't see very much rash, I know that, so it's going to be really easy to just pinpoint these. So you've got Zika symptoms or a pregnant person plus an exposure. That's who you want to even consider testing in adults. And again, exposure means traveling or sex with somebody who has traveled to a Zika-affected area. You want to order urine and serum. Say it, urine and serum, both at the same time. And you want to get a PCR assay or NAT testing previously within 2 weeks after symptom onset. So this is for anybody who has symptoms, you want to get it within 2 weeks. And for symptomatic individuals, you want to get the IgM from 2 to 12 weeks. So this is symptomatic, non-pregnant people. You want to get the PCR within 2 weeks and the IgM from 2 to 12 weeks. These are the same as the old recommendations that are posted online. However, if they're pregnant, you want to get both the PCR and the IgM. This is symptomatic and pregnant. You want to get PCR and IgM at the same time. Why do you want to get them at the same time? Because we now know that PCR can persist, viremia can persist longer, and the PCR can be positive longer. And because bringing those pregnant women back is such a pain, we're better off getting the specimens at the same time and getting both PCR and IgM. That's our best chances of diagnosing these pregnant women with symptoms. And again, if you're pregnant with symptoms and you've been exposed to a Zika-affected area, you're at the highest risk and most likely to be positive. Now, if you're pregnant and you have no symptoms, this is what I said before, but I'm going to repeat it again. If they have been in an ongoing exposure to Zika-affected area, so you have somebody, we just had a phone call 2 nights ago, somebody who's been living in Guatemala and shows up here for care, that ongoing Zika exposure, you want to get serum and urine once every trimester. No IgM for asymptomatic. If you don't have ongoing exposure, so you have somebody who maybe just went to Brazil or Central America for a trip and they come back, CDC is very clear that they have absolutely no clear recommendations on what to do with those individuals. So they're basically saying, talk to your patient, they've had a brief exposure. The only test we really have is this IgM, which is more likely to be false positive than it is likely to be a true positive. If that patient is so anxious, they would rather have some test than no test. From a local public health standpoint, and these have not been established yet, we're gonna support you guys if they're pregnant. And most of the time, though, it's going to be really hard to interpret that IgM test result, so we probably would say don't order it. But I think we really don't know where we're going to go with that. Lisa, do you want to comment any more on that?
That's national guidance that just came out yesterday, and so states don't have to follow that guidance. We've already heard murmurings that California is not going to implement this guidance. So Arizona, the state health department, is speaking with the counties to try to figure out what our testing guidance is going to be going forward.
Okay. But the other take-home message, besides serum and urine, is that you can call public health. Every single time you call us, and we're going to help you. Vaccine development, Nick mentioned it briefly. We put this in here because we wanted you to know that there's multiple vaccines that are in trial. I believe the latest one is in phase 2. Have any of them hit phase 3 in the last couple months? Not that I'm aware of. Who knows what's going to happen with vaccine development now that the world incidence is going down? I'm not clear on that, but we know that they have developed a vaccine, so we think they can do it, and we're just waiting for more data. Very important prevention messages. Everyone should prevent mosquitoes and sexual partners from Zika exposure. So if individuals are traveling to Zika-affected areas, make sure you're using insect repellent. DEET is a good thing. You can use lots of them, picaridin. There's other ones, any EPA recommended repellent, but DEET works really, really well. The higher the concentration, the better. As far as DEET in pregnant women, the EPA is and CDC are very clear that it's way better to wear insect repellent than when you're pregnant than it is to give your kid Zika. So don't worry about that. It's important for women to use condoms when they're in a Zika-affected area, or if they've had a partner who's been in a Zika-affected area, and that is for the duration of the pregnancy. Of course, watching for symptoms and talking to your doctor if there are any symptoms. Pregnant women are where we're really honing our messages, most specifically about mosquito prevention, avoiding travel to Zika-affected areas, and then if there is travel, making sure that you wait the right amount of time before attempting to conceive, or using condoms if you're already pregnant, or if you're not pregnant, attempting to conceive. And then women of reproductive age need to have a reproductive plan. These are a variety of choices. Women should wait 8 weeks before attempting to conceive. Again, it doesn't stay as long in women as it does in men, and these are conservative estimates. But because it persists so long in the semen, men and couples who have both been exposed should wait to conceive for 6 months. So those are big numbers that you should remember. And we are always available for questions about testing. We can help you with any concerns about reports. We can help you figure out if the area that they traveled has actually had recent Zika circulating. We can help you on which tests to order, which labs carry what tests, what the turnaround time is. That's our phone number. And in case you have a patient that is outside of Maricopa County, we've conveniently listed every single county's phone number for your pleasure. And that, do you want to do your MOC before questions or after?
Yeah.
Okay.
All right. So everyone can get credit for being here. We have one of these questions. Does everyone know how to do this? So I think the easiest way is from your phone to text your answer there. So someone did. So someone figured it out. So the question here is a pretty basic one. So from a clinical perspective, acute Zika virus infection may present with all of the following symptoms except. And I don't know if I can see how many people have responded. It was a pretty easy question, so maybe.
Don't make them feel bad.
Well, no, well, okay. Except, right, this is kind of like board prep again, right? Carefully read the question. Good enough? Sharon? Yeah, good enough? Long enough? All right. So the correct answer as identified here was hemorrhage, right? So an important distinguishing factor between Zika virus and dengue virus is hemorrhagic sequelae. So if you have a patient coming in with fever and rash, and they have been in Zika and dengue infected areas, one of them is hemorrhaging and the other is not. The one who's hemorrhaging probably has dengue. Okay? All right, so that's the end of our presentation. So if anyone has any questions.